All right. Good afternoon, everybody. My name's David Williams. I'm from the World Health Organisation, but in a previous life, I was a researcher who spent 20 years in Papua New Guinea. Started out at a time when we had no resources and we went anywhere. We had to go in public motor vehicles, which are 10-tonne Bedford trucks. About 40 or 50 people cram into the back of them with their pigs and chickens and whatever else they happen to have. And you hopefully get from point A to point B. When I first went to PNG in 1995, the highway out of Port Moresby went for about 40 kilometres before it hit dirt. And after about another 40 kilometres, the dirt disappeared altogether. So going 100 kilometres could take you all day. And trying to do epidemiological research this way, you very quickly learn that you need to start talking to the local people. And when you first start talking to them, you find that there are lots of preconceptions and misconceptions and myths and legends and sorcery tales about snakebite. But the good thing about this as a disease is everybody's ears perk up. They're all terrified of snakes and they all want to learn something. But it's finding a way to be able to put a message in such a format that you're not actually offending people's traditional views. Early on we found that that was one of the potential pitfalls. You couldn't just come out and say, look, you know, this stuff that you're using is just rubbish. That wouldn't get you very far very fast. In the end, our strategy ended up being that we were quite willing to have you use your traditional medicines if you brought them to the health centre. And we sold it on the basis that it was like having 2 tickets in a lottery. We're going to use our particular type of medicine and you're going to use your particular type of medicine. We've got 2 chances that this person will live. And of course, over time, with more people coming to health centres and more people getting good medical treatment and the outcomes getting better, and I mean by better, when I first went there, 14.5% of all the adults died and 25.9% of all the children died. So that's 1 out of 4. By the time I left last year, we had those figures down to less than 1.5% across the board. But as those figures improve, people vote with their feet. And we went from seeing a handful of people in emergency departments to seeing 450 or 500 people a year. Not because of a snakebite epidemic, but simply because people eventually got the message, and the message was disseminated by them at ground level, that if you wanted to survive a snakebite, really you had to get to hospital, and this particular hospital was the place to be. But I got pulled out of all of that in 2015 when we started looking at trying to get WHO to put snakebite on the NTD list. And as Jimmy said, he was shooting a documentary in April of 2016 with me in Papua New Guinea, and we were sort of starting to think about going to the World Health Assembly to do a little side event to try and raise awareness. And we really had no idea about what a communications strategy would be. We were a group of scientists from around the world that were passionate about the subject, and we wanted to convince countries that this was something they should support, which is where having somebody with communications background came in very well, because the vision that they were able to show really was the selling point to get people at the World Health Assembly to take some notice. It led within a year to the development of a dossier to have snakebite listed as an NTD, which Margaret Chan approved as one of her last acts on her way out the door in 2017, followed in 2018 by a very robust resolution passed by the 71st World Health Assembly. And last year, at the 72nd, we had the launch of a strategic roadmap. And unfortunately, you have to be very careful about what you wish for, because I've been stuck with the job of putting most of this together and trying to get it to move ahead. So I'm now based at WHO trying to implement the program and move it forward. But when we sat down to write this, I used the experience I'd had in Papua New Guinea, where realistically, if you wanted things to change, you had to actually be able to convince the people that were at risk, the community, that it was in their best interests to change behaviour. And that's not an easy thing to do. So when we wrote this strategy, we looked at it from three perspectives. And yes, having the right treatments is very important. Having antivenoms and other medicines that are safe and effective and accessible and affordable. It's also equally important that you have to have a health system that's functioning, and functioning at the scale where these people turn up, at the little aid posts and rural health centres. And if the right resources are not available there, well, then you'll still have problems. But of course, people say about a lot of things that prevention is better than the cure. And I think for snakebite, that's very true. I mean, most people, if I was to ask you guys, what's the worst thing that's going to happen to you if you get bitten by a snake, what would you all say? Death? Maybe. About 138,000 people a year die of snakebite. 400,000 are left permanently disabled, either physically or psychologically. Now put that in the context of the number of new landmine injuries per year and the resources that are put into curtailing landmine injuries and rehabilitating people. That's about 6,500 people a year, the current rate. Snakebite completely eclipses that, yet there is no effort at rehabilitation. There's no effort at recovery written into any of the protocols for the management of snakebite. I've seen women in Cambodia who've been rubber tappers, stepped on a Malayan pit viper and had their leg rot and fall off over a period of a month. And I mean literally rot off the bone until eventually the rest of the leg is amputated. And they no longer can go outside their homes. They have no role in the community whatsoever. They sit inside a room at the back of the house and they're considered to be worthless people. They're a drain on the family's resources. I've met young girls in the same situation whose fathers have kicked them out and they're sitting on street corners in Phnom Penh begging because they have no value to the family and the family can't afford to feed them. So for snakebite, there could be worse consequences than death. And certainly in terms of broad numbers, the disability aspect is a completely forgotten area. And again, it's partly because of a lack of communication. People don't realise that this is such a big problem. So community engagement was the third major pillar of the roadmap that we've developed. And this year, WHO is setting up a roster of experts, and we're setting up a committee that's going to look at developing a communications toolkit and a range of resources that can be used in countries around the world that targets the audience that we want to reach, which are people in villages from mostly the poorest communities in all of these countries. Often they're marginalised communities, so in Kenya they're often nomadic herders. They're not viewed as particularly the best people to have around. Because, you know, they've been involved in things like farm invasions, wanting to have land to have their cattle graze on. In India, many of the people who are affected are of the lowest caste. So there are problems there with the government recognising the need to invest in solving the problem simply from the view that these are people that just fall through all of the safety nets. But WHO's strategy looks at community engagement and community empowerment. We know that it's a lot easier to be able to prevent a snake bite, and there are simple things that can be done that have got a lot of duality with other neglected diseases. So, for example, if you're in India, one of the main causes of snake bite is a snake called a crate. It's nocturnal. Most of the people who get bitten at night while they're asleep. The simplest, easiest way to prevent that is to get people to sleep under mosquito nets, to tuck them into whatever bed or mattress they're sleeping on, and to sleep that way. You can completely prevent it from happening, because these are snakes with potent neurotoxins. You require mechanical ventilation more so than antivenom for treatment, which simply is not going to be available at the places where they're going to be taken to after they get bitten most of the time. So the ability to message there is very good. We've had some good discussions with the Medicines for Malaria venture people about applying messages around snakebite to the use of bed nets in sub-Saharan Africa, because, again, sometimes people don't see the connection between a little buzzing insect and a disease that affects them weeks later. But they all know that they have children in their villages that get bitten by spitting cobras in the night. And they all know that that's something that they don't want to happen because, again, those kids lose their arms and legs, they rot and fall off. So these are some of the things that WHO thinks are priorities, is improving the way that we communicate. But we don't want to try and reinvent the wheel. We would much rather be able to draw upon resources from people who've already been looking at some of the messaging issues related to other health issues, other disease issues, and working in the same countries around specific ethnic issues around communication, on how we can best approach being able to bring out a toolkit that people can use. So if you go to the WHO website and you look under the snakebite health topic, you'll see a link to a page that is calling for people to express interest in being part of the group that are working on this particular problem, and we really would welcome input from anyone who thinks they could help us. Okay, thank you.